Welcome everyone to today's webinar, Second Wave Preparedness, Infection Preventionists and Pharmacy Leaders Discuss Patient Safety and COVID-19. I'm Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, I am pleased to turn the floor over to Stephanie to begin today's presentation.
Thank you, and thank you so much to everybody for joining us for this webinar. The webinar today is sponsored by Vigilance, the leading provider of clinical surveillance solutions for hospitals. My name is Stephanie Kovac, and I am the Chief Strategy Officer for Sage Growth Partners. We are a healthcare-focused market research, go-to-market strategy, and strategic marketing firm in Baltimore, Maryland. Today, we're going to discuss patient safety and COVID-19, a topic that many of you have wrestled with and will continue to wrestle with for months to come. We're super excited to have several panelists here with us today. We have Joshua Corder. Joshua is a clinical pharmacist specializing in antimicrobial stewardship and general pediatrics at Cincinnati Children's. Joshua has been with the health system for 18 years. Among his roles and responsibilities, he served on a multidisciplinary team that sought to reduce vancomycin-associated acute kidney injury, in which he received the 2016 ASHP Foundation Excellence in Medication Safety Award. We also have Jessica Liberty. Jessica has been a registered nurse for more than 10 years, starting as an emergency room nurse and migrating to an ambulatory surgery center nurse with infection prevention and clinical compliance responsibilities. In December of last year, Jessica transitioned into the infection prevention and control manager role at Freeman Health System in Missouri. We have Joanna Mills. Joanna is a clinical nurse specialist and clinical infectious and communicable disease prevention and control practitioner. She's the director of infection prevention for the John Muir Health in the East Bay area of San Francisco. Joanna has over 30 years with nursing and clinical infection prevention knowledge and practice in a variety of healthcare environments ranging from ambulatory care, home health, long-term care and rehabilitation to acute care, teaching, and professional organizations. And finally, we have Michael Sanchez. Michael is the postgraduate Year 1 Pharmacy Residency Director at Health First Homes Regional in Florida. He's been with Health First since 2010 and as a pharmacy specialist, he takes on projects in a variety of fields, including antimicrobial stewardship, anticoagulation, and trauma. So with those introductions, we're going to get right into the conversation. So I'll be helping to facilitate us through a series of topics and questions, and we're going to start with safety challenges during COVID-19. So the first question is for all panelists, and the question is to briefly describe the experience at your hospital during the height of the pandemic. Kind of what is your role at the time, and what are you guys dealing with or facing in today's environment? So we'll start with Joshua.
Yeah, so at Cincinnati Children's, being a pediatric institution, we fortunately did not see a large influx of patients. Still, actually, until the past couple of weeks, we've actually had a relatively few number of patients who are COVID-19 positive. However, there are a lot of operational changes that had to happen to make sure that our operations are safe for our patients and our employees. So I think that was really one of our big changes. And actually, just as an update, in the past couple of weeks, we've seen quite a few more COVID-19 positive children than pretty much March and April.
Okay, great. Thanks. Joanna, how about you?
Yes, my role as the systems director has been quite active from the onset. We here in California, especially in the Northern California Bay Area, saw the very first cases of COVID coming in from the cruise ships from Japan. And since that time in late February, we've been really I think other people will share my comments of insanity, unknown insanity as we go forward in the pandemic. And it's really been a constant adaptation. We really have seen some slumps in activity in terms of the community incidents and also hospital incidents, but it's been fairly constant and ever-changing from the onset, and quite a challenge, frankly, in dealing with patient populations, but primarily staffing and the staff's both information and education relative to whatever current stage we're in and what they need to keep them safe.
Have you seen, how have things progressed from March to now? You saw a flattening and then a big spike. Are you guys in the middle of a spike right now?
So there was a very brief period where we had, and I believe that was in kind of April, mid-April, where we had kind of a slump in hospital admissions to the point where, we had designated units for the patient population, for the COVID patient population, and we kind of went back to, the normal housing of patients at that point. However, since then, that was very brief. That was only about a 2-week period of time, and now we're seeing a similar surge both in inpatient population and also the outpatient arena has been pretty well inundated as we try to ramp back up in terms of those services.
Okay, great. Jessica, how about you guys?
Well, we are kind of like Josh in that sense. We are an acute care hospital in a Southwest Missouri area, and most of anybody that's familiar with the Joplin area may have remembered that, we had the Joplin tornado about 9 years ago. But we, at the very beginning when COVID hit the U.S. in March, we initiated our incident command with the leadership team here at Freeman, and we developed several processes, as I'm sure most of other facilities have, employee or visitor screening. We developed our COVID-19 policy with algorithms. We developed a COVID call center and drive-through process and PPE conservation policies and all of that, but we just didn't really have the numbers to support that. However, towards the end of May, we started to see our surge within the Southwest Missouri and four-state area, and we've continued to walk into that the whole month of June and walking into July, and with all of the processes that we had developed early on, we have been able to, continue with that and work on, the education with our healthcare workers and other staff members within our health system.
Okay, great. And Michael, I think next to you in Florida is kind of going through some strange times now. Right now too. How has things progressed for you guys?
We're certainly on the mainstream news. So just some background on Health First. We're a 4-hospital health system in Brevard County. That's the Space Coast of Florida. So if we can see a rocket launch, then we know we're on the Space Coast. So with being a county-wide health system with a health plans, a medical group, our hospitals and outpatient services, it's encouraging to see that other health systems, we had very similar setups as far as executive support and a task force, basically helping to organize an action plan and react to all this, but also just to prepare in advance. So, for example, when we had our first, I wouldn't call it a wave necessarily, more like a trickle back in May, we were able to conserve PPE and have all of that all set up, really well in preparation. I would say actually just in the past week and a half, now this is a true wave, and the hospitalizations have really increased for Florida as a whole, along with the cases. And for the most part, thankfully, mortality rate has stayed steady. However, there is maybe just the very beginning of a trend where mortality looks to be about similar to what it was back in May, as far as daily fatalities. So, I know that's a lagging indicator as well. So we'll have to see on what happens with that. From a health system perspective, it's been multi-pronged as far as drive-through testing, virtual visits on the outpatient setting for the hospitals. I know from my role, I've certainly made a lot more contacts than I ever thought I would on the IT side and on the lab side, just to help with really optimizing a pharmacy response and being able to integrate our team into just that daily surveillance for the COVID patients.
Okay, great. That's super helpful. So I think, you guys are all in the midst of this, maybe at varying levels of intensity, and it surges and wanes as we go, but patient safety is at the top of everybody's list these days, right? Making sure that patients feel safe, and more importantly, that patients are safe. So as you think about how you've managed through this, what has been kind of the biggest patient safety related challenge your organization or department has faced during this, and some of the things you did to address that challenge? I'll let somebody volunteer to go first. Or Michael, let's just start with you.
Yep. Yeah.
Oh, Josh, go ahead, please.
You can go ahead, Michael.
Sure. Just from a safety perspective we have all of these tests going through for various patients, and just like a normal culture result, there is a transition of care type of issue that can come up even with COVID tests. So, we already had an antimicrobial stewardship program, of course, set up to detect cultures that may test positive or after a patient's discharge, and pharmacies able to have surveillance for that and contact patients or the primary physicians after discharge. But COVID was very, very new, of course, back in April, and it was a very manual process. I understand that our infection control, there's a lot of manual detection and contacting patients to inform of results. Well, at the very beginning and throughout this whole ordeal, pharmacy, we had some surveillance alerts set up for COVID, and this is where, we've certainly detected some patients who were discharged, and then the COVID results come back positive after discharge. One that really stands out in my mind was a particular nurse who was at another institution, was discharged from one of our hospitals, and surprised, their test came back positive. Now, because it was a manual process, that notification would certainly take time. But with this instant surveillance, we're able to, as a pharmacy team, jump in and help with the immediate notification, basically helping to make sure that nurse would be self-quarantined. And we've actually seen multiple instances of this. Another patient, for example, going to a rehab, discharged after negative test. However, a repeat test showed up positive. Having that immediate surveillance and just being able to reach out and make sure that receiving rehab able to divert that patient and make sure they're getting the right care, but also the tracking that might be needed for any possible exposure. So just the timeliness of surveillance has been a big safety plus.
Yeah, that's great. Josh, you want to, from your perspective?
I think that one of the largest things that we've seen is just, supply chain management. So, having the adequate PPE to make people especially our patients and the children, comfortable to come in and, have the surgeries that they need, or, also equally important, making sure that they stay up on their vaccination schedules and that they can make their healthy visits, because you can't really necessarily do everything via telemedicine. So I think that that was probably some of our biggest barrier, but, using some of our real-time surveillance to, detect when you can remove somebody from N95 precautions. So I think that some of those things definitely helped us out.
Okay, great. Jessica, from a patient safety perspective, what has been your biggest challenge?
So kind of like with Josh, the timely notification of our COVID positive results, has been up until just actually in the last few days has been a very big, heavy manual process. It's primarily fallen on myself and my infection prevention team. I have 3 others that work in my department, but, through this surge in the past month, the lab has been the one that's been notifying me of the positives, and then I have in turn notified those patients. And one of the biggest safety-related issues that I've seen is that in our rural area, we serve a very large Hispanic, Guatemalan, and Micronesian population. And so there is that language barrier, and anybody that's worked with Pacific Islanders know that the island that they came from, they speak 50 different versions of a particular language, and so there's just not interpreters that are readily available to be able to answer those questions and even, relay the results to those patients. Many days I would get on the phone with these people and I would not have any way of communicating that to them. And so I've been working with our health system to kind of break down that language barrier, because of a lot of the those subpopulations within our area are, have those underlying comorbidities and have been, generally speaking, have made up more of the sick population. Most of our inpatients right now in our COVID unit have English is not their primary language, and they have underlying renal disease or coronary artery disease, and so they are generally just sicker. So that's been one of our biggest issues, is being able to effectively communicate instructions as it relates to COVID, and for me to be able to notify them in a timely manner, to be able to get a hold of them, with a working phone number. That's been one of my biggest challenges as it relates to patient safety.
Joanna, do you want to answer the question about patient safety?
Sure. It's, the surveillance piece has been obviously the biggest challenge, especially related to contact tracing. I think the previous comments that were made by the others really reflect the necessity for not just that immediate notification of the positive results, but the contact tracing, whether it's as a result of exposure to staff or for patient tracking as well. And that's one of the things that has been particularly helpful with the vigilance system, in that, the EMRs are kind of clunky when it comes to, creating reports and having, those real-time functionalities available to, especially infection prevention, but other staff as well. So we've really become dependent upon not just the immediate notification in the surveillance piece, but also the adaptation that occurs on a regular basis. One of the things that we've learned during this entire pandemic is that it's very fluid. And, what worked yesterday will not necessarily work today nor tomorrow. And so that immediate responsiveness, being able to modify those alerts, that, on an ongoing basis makes the most difference in getting that immediate information is the thing that has been really imperative in terms of being able to do that contact tracing and making sure that patient and staff are safe, especially with the limitations that we have in some of the testing capacity. So that response has been critical to our patient safety and also staff safety elements in the pandemic.
Oh, that's great, Joanna. Thank you. So I think we've heard you guys all talk about patient safety and talk about staff safety. I think visitor safety is a big issue, too. I know so many hospitals are managing that by really not allowing visitors in. But have any of you guys done anything particularly interesting around visitor safety that's worth talking about in, thinking through clinical surveillance capabilities? So, okay, let's, Mike, I know during the pandemic it was critical to really ensure that COVID patients were isolated to kind of halt that spread. And from what I understand, you had one patient that was discharged without notification. And is that kind of relate back to some of the things you were talking about, or maybe talk about that experience a little bit more depth?
Yeah, it really was a way that, from a pharmacy perspective, trying to incorporate the surveillance team on not just on the COVID patient notification, but also on the clinical side as far as the evaluation of the medications and right dose, right patient, along with monitoring parameters. As far as that that one particular patient, it was really interesting. I'm glad to see a panelist who was also involved on the notification for the patients, and you had a really interesting point how you needed the right contact number. Well, this one particular patient, they didn't provide a correct contact number, and so one of the nurses reached out to me because I was involved with some of the patient on the chart, and we were just basically sleuths trying to figure out how to get in contact with this positive patient who could be out and about, possibly spreading. But eventually, with enough teamwork together, we were able to get to contact that patient. I mean, it almost reached the point of using social media just to find some of these patients. But from pharmacy side, looking at some of the antiviral regimens. Early on, it was, of course, a lot of the hydroxychloroquine and azithromycin. We had the convalescent plasma for some patients. We even thanks to one particular article, one patient got ivermectin. It was during that time where there were publications, dozens and dozens coming out almost like every day, and it was just you never knew what to expect. You hear something on the mainstream news, and you're already getting prescriptions for it, in the pharmacy, on the hospital side. So it was a very, very rapid time to adapt to things, and then to just to make sure monitoring parameters were safe, and to come out with recommendations for the providers so that they have good evidence-based guidance, at least the best evidence that is out there. Now that a few months have gone by, we have some better firm guidance. Of course, trying to go towards more remdesivir, but we still have convalescent plasma and some other options. But really curious, how the evidence will continue to evolve, and having seeing that positive result real time. That's everything from pharmacy being able to make recommendations, notify the physician, but also looking at the EMAR, looking at the administration times for all these various drugs, and reducing the contacts with the nursing team. It's just an altogether package that thanks to the surveillance, pharmacy can integrate into the COVID response.
Right.
Michael,
Great.
I have to agree with you, Michael, on that. So we actually have a COVID-19 treatment team, and so that's several of our ID physicians. We have, BMT and oncology docs. We have rheumatologists who are all working on this team. And the ability to get real-time notifications to that team via, either text message or email, just letting them know that there's a positive to go and look at, that's been really pivotal in allowing that team to take a look at the patient and then, looking at, not only remdesivir and convalescent plasma, but we also have a trial for DAS-181. But, just saying, okay, what kind of treatments would this patient potentially benefit from, and are they eligible for any of these trials? So, yeah, I absolutely agree.
Josh, I think I'm interested in your perspective from a children's hospital. Do you think your experience is different than, kind of a standard acute care hospital? Do you have anything unique around that? I know you talked about one, right, with patients not being parents being afraid to bring their kids in for immunizations, and there's a lot of that's been in the news. Are there other things around your experience that you think is different or unique?
Yeah, so we have a couple of unique things with pediatric patients. So one is that, of course, they're, from what we've seen so far, less likely to turn up in the hospital sick. So most of our patients, are almost asymptomatic, and they're ambulatory and do not get admitted with COVID for our patients who do test positive. But then, of course, we also have the other side of that, which is that Kawasaki-like disease that we've been seeing in pediatric patients around four or so weeks after they have had COVID-19. So that's referred to as a couple of different acronyms. So one is PEMS, which is the Pediatric Inflammatory Multisystem Syndrome, or MIS-C, which is Multisystem Inflammatory Syndrome in children. Basically what it is this thing that kind of looks like Kawasaki disease, but also tied with a prior exposure to COVID-19. At our hospital, we are lucky that we have some really cool labs. So we have a PCR lab that was able to come up with on-site COVID-19 testing back in, early April. So that really upped our ability to get into some of the clinical trials, as well as testing more patients and actually even employees. So I think that's been helpful. And then as far as the PIMS diagnosis goes, we actually also have our on-site testing of IgG for COVID-19. And that's also tied into some of our real-time alerts that go out to the COVID-19 treatment team. So that's definitely been helpful to take that new information and get it to them. But, definitely looking back into, early April, before we started having on-site testing for COVID-19, we started out with like a 10-day turnaround time, but then we were able to get that down to about 24 hours. And then now they have multiple a day that run. So less than 24 hours to results, which makes the real-time alerting that much more successful.
Yeah, that's great. I think that's helpful. So, I want to move on a little bit. I know that, there's been a lot of talk of the second wave, and, Michael and Joanna, you guys might not feel, Mike, you guys are in the midst of probably the first wave in Florida, and Joanna, I think, out where you are, it's been a weird kind of evolution of COVID as well. Jessica and Josh, you guys in Ohio and Missouri are maybe a little bit calmer, and maybe a second wave sounds more real, or rather than in the midst of the first. But as we prepare for this moving on, are you guys doing anything different? How are you thinking about kind of preparing for that, or what are some of the lessons you've learned up until now that might change the way you operate to really focus on patient safety, or just general management as we move into further into this, or even a second surge in the fall?
Yeah, this is Mike. I can start.
Yeah, please.
You know, something that we have, thanks to the time that has elapsed, is more patient data. And I mean, one of the things that we just anecdotally at first saw on rounds was of course what New York was seeing as far as the VTEs, and so we, you know, recently we were able to get very quickly a report from Vigilance just on our anticoagulation for all of the positive COVID patients. This was, you know, this has multiple data points, everything from the dosing that was prescribed, you know, the type of prophylaxis, the D dimers, and all the monitoring parameters, and we were able to get a sense of just, you know, what type of improvements we needed to have. You know, were there a lot of patients, for example, who were getting full therapy, full anticoagulation without, you know, confirmed VTE? Were we using much of the higher prophylaxis dosing? So, you know, from that type of report that's also through that you can build through Vigilance, you know, we're able to answer some of those questions, and we do have some updated order sets coming through very quickly, basically as a response from all this experience over these past few months.
Okay, great. Jessica, how about from your perspective? Do you guys have a plan?
Do we have a plan? Well, we do. So, we initiated a plan with the incident command team back in March, and we were kind of able to withdraw, some of the processes because we just didn't have the numbers to support it. But now that we're currently in our surge, one of the biggest things that was developed and birthed from COVID was developing a COVID call center and a drive-through process. And this was actually a collaborative effort between another local hospital in Joplin and then our local health department. And that process initially started out, fairly small. The needs really weren't that great. And then our other local hospital and the local health department backed out of the process, and it became just a Freeman-based entity. And we kind of just got on the skeletal, or skeleton crew staff that would come in and man this process, and I oversaw all of that and refined all of our processes and kept up to date with, all the CDC guidance and, all the recommendations for indications for testing and all of that, and developed an algorithm, all that. And then once we hit our surge at the end of May, and we've, sustained our numbers and have continued to grow, we have actually moved and developed a semi-permanent process for the drive-through in the call center, and I now have a subset group of people, a department that I have created with 11 staff members that are going to be staffing this process at least through the end of the year. And our anticipation is that, our first and then quote-unquote second surge that we may see, that they may kind of just bleed into the other, just given the way our situation is right now in this area, that, we're coming into the influenza season, and we're talking about, what are some of the things that we're going to, continue to need or possibly see. And so there's been discussion, the continuing that process through the end of the year to meet the needs through our sixth season as we enter into influenza season. Then also, some of the processes that we that we have implemented for flu season, we're looking, like mask wearing. If you don't, take a flu or if you don't, receive a flu shot, everybody right now is wearing a mask. And so there's been open discussion on, having healthcare workers continue to wear a mask even through the end of the year as we, as kids go back to school and everybody, gets exposed and, that sort of thing. And then, one of the other biggest things is on the clinic side. There's been a lot of hesitancy from providers, and I think a lot of it's fear-based, to educate them, but then also, help them to work on a process to care for patients that have COVID and that don't have COVID, and, helping them, meet the needs of their patients by having the patients wait out in their car instead of having, heavy loaded, waiting rooms, but have them there to kind of decrease any potential exposure, and then having patients and family members wear masks if they are in a clinic setting or if they're in the hospital setting. So, those seem to be some of the biggest, things that we're looking at from a health system standpoint, moving into influenza season and potentially a second surge.
Yeah. Okay, great. Joanna, how about you?
Yeah, lessons learned obviously are ongoing, but the one reality that I think is important to recognize is the fact that, especially here in Northern California, this is going to be a pretty constant situation up to and including the upcoming flu season. And frankly, I anticipate it being much worse with the kind of influx of influenza and the other upper respiratory viruses that are identified in that period of time as well. And so I think that the key element here is to give staff and patients the most information that we can to help them to understand that we won't have a reprieve anytime soon. And this will be, as is said in the media and everywhere else, the new normal going forward. Our plans are pretty concrete at this point in terms of really having what we need to really function safely and, take care of our patients. I certainly appreciated that comment about, outpatient services, because I think now as those services resume, that, for the future is going to be the challenge, because there's still, even, with the providers, there's still, a lot of unknowns. There's a lot of fear out there. But, we really do have the systems in place to adapt to whatever the next change may be. So if there's any message at all, it's that change is going to be constant, and we need to be flexible and adaptable with every kind of turn of this particular pandemic, because it'll be fairly ongoing.
And would you say, when you think about the resumption of ambulatory services, right, and patients coming in and feeling safe, and thinking about the clinical surveillance capabilities that you have, what are the highlights? Like, where are the specific opportunities that exist with the clinical surveillance capabilities that wouldn't have before?
Those capabilities are really dependent upon how the patients are being pre-screened prior to their visits. And those are the pieces that, especially for the procedural elements of whatever the outpatient visit is going to be key to the resumption, because, clearly it's a different level of care. However, when you have clinic environments that have the capability to do interventional and diagnostic procedures that could potentially be aerosolizing, those are the situations where you really need that surveillance, the pre-procedure surveillance opportunity to really keep things as safe as possible. Clearly testing is not perfect, but it's all we got at the moment.
Right.
And so we really have to capitalize on that, and the way to do that is with the surveillance piece.
Great. Okay, great. Josh, how about you in a second wave? Are you guys starting to think about that and plan for that?
Yeah, I think that, to be honest, I think that we have everything in place that we're probably going to from a surveillance standpoint. So really, now that we're testing a lot of people, we're getting the results and acting on them. I think that really one of the biggest things that we learned and we're doing is the universal masking for all visitors, all employees, all patients. So I think that that's one of the things that we learned. So now it's just getting folks to do that. And just as one kind of sunshiny thing, one of the nice things that our visitor services did recently is that they actually started sewing masks for the entire community. So it looks like they've distributed like at least 1,500 masks to our local charities, and so I think that that's one of those things. Just moving forward is just making sure that people know what the right thing to do is and to do it.
Okay, great. So I want to make sure we have some time for Q&A. So I want to spend a little bit of time on some kind of helpful resources for the folks in the audience. Here are some resources that Vigilance is providing to help hospitals like yours really confront the COVID-19 pandemic. COVID Quick Start is a new offering from Vigilance. It's designed to help hospitals prepare for, prevent, and respond to the spread of COVID-19 and other respiratory viral illnesses. It includes a specific set of respiratory viral illness monitoring and prevention functionality, and it uses a proven rapid deployment API integration powered by Datica, making it IT light solution that can be up and running in a matter of weeks. And Vigilance is also offering no payments for 6 months, making it even easier for hospitals to get access to this critical infection prevention technology. Just a reminder, if you do have a question, please submit it in the Q&A button at the bottom of your screen. And we'll move to questions now, I think. So, Michael, I think we're going to start with you. So here's a question from the audience. With the new hydroxychloroquine data from Henry Ford Health System, are you utilizing HCQ in absence of backup from FDA? Or how are you kind of dealing with that?
Yeah, I think we're all interested in what everyone else is doing. Just on treatment in general. For example, Josh, I'm really interested in what your side is doing too. For just to back up, at the beginning of it all, we had surveillance daily as part of the positive test, where if they were getting azithromycin, hydroxychloroquine, we were making those recommendations to make sure EKGs were ordered, making sure the monitoring parameters are all appropriate and looked at. We actually made a lot of interventions discontinuing the combination because of QT prolongation. It was a significant number. So it was definitely not benign in that regard. So for right now, our algorithm for those severe COVID patients, it is your corticosteroids, going to dexamethasone. If we can get an antiviral on board, LFTs are appropriate. We're going straight to remdesivir, especially once it's to be made available commercially soon. And then when these things fail, worsening, going to convalescent plasma or the monoclonal antibody. So that's our current type of algorithm. We don't have hydroxychloroquine, azithromycin on that treatment pathway. Where it's tough to say as far as what evidence is really pointing towards. We all want that strong RCT to give that final say. I mean, it's great that's that Henry Ford article, very large retrospective observational trial, but we're really hoping for that RCT, just because the combo, it just based off of what we had seen, there is some significant risk if it's not for that right type of patient. Curious on Josh, on your side, what did you think on the hydroxychloroquine side? Well,
back in the day when it was less controversial, we did our institution went in for the thing where you could actually pay for a company to produce hydroxychloroquine so that you would not impact the supply to your currently existing rheumatologic patients. So I think that we have a couple kilograms of powder, but it was kind of a better safe than sorry without impacting people who are on it for other needs. But yeah, so we have definitely removed hydroxychloroquine from our algorithm. So right now, it's pretty much remdesivir. We have some information for patients going down to 3 months of age. We haven't had to use it. So convalescent plasma is also on our list, and then, like I was saying, DAS 181. And actually, steroids are still kind of controversial in pediatrics just because all of the data that we have is from adult patients. So really, we don't really know. So it's kind of a judgment call when the COVID treatment team comes for the consult.
Great, super helpful. Okay, Jessica, here's one regarding masking. So, how do we navigate, the question is, how do we navigate the Emergency Medical Treatment and Labor Act with regard to masking, and how are patients at the ED handled if they refuse to mask? Any thoughts there?
Well, yeah. So one of the things that we've implemented within our health system is that any healthcare workers they're wearing a procedure mask during their shift. So there is a level of protection that's given to our staff and on that sense. And I know that for the most part, anybody that comes through the emergency room, aside from those that are considered critical and maybe come in through EMS, have been very sensitive to the request. And to my knowledge, there hasn't really been anybody that has thrown a big stink about it, because I know that there is definitely heightened awareness and a baseline fear from the community as it relates to COVID. And so if there is a recommendation, most of the time they will put it on. However, we do not refuse care. We do, at the front, at the entrance, we have limited entrances now into our facility, but one of the things we have is a greeter who, one, just makes sure that, we have our limited visitors for our inpatients, and then two, they also say, hey, we are recommending based on our COVID surge at this time that, all patients and visitors wear a mask. And any of the pushback that we've gotten, it hasn't been so significant that they haven't not worn a mask, to my knowledge at this point. And however, if we were to, come into that and, somebody would just be very adamantly and refuse that, then, we would not refuse to care for them. And like I said, it goes back to the level of protection that, we are giving our healthcare workers who are caring for them because they are wearing their mask.
Great. Thanks. Joanna, kind of on this mask topic, but not patient, kind of relative to PPE for staff, right? There's been a lot of mention today about masks and PPE to protect staff. Are there any major tweaks you've made for them? Have you done anything in particular about just general equipment and anything to take extra measures to protect your staff?
Yes, well, from the onset, we have been pretty diligent about, supply. So the advantage was that we really never were in a place where we had any significant shortages or, threatened shortages. So the things that we tweaked along the way as the recommendations changed were, the addition of, face shields and conversions of some of our inpatient spaces to negative pressure and those accommodations. But the biggest challenge in terms of the PPE and training piece has been not necessarily, from the inpatient perspective, has been really kind of ramping up training for PPE use, especially PAPR use, for those physicians and procedural providers that have a higher risk relative to their procedural work and aerosolizing, generating procedures that they would perform. And so that ramp up and the acquisition of those PAPRs and the training associated with that, and providers that wouldn't necessarily have otherwise used N95 masks or respirators now have, the added challenge of not just training but fit testing in California, and I believe nationally relative to NIOSH and the CDC. Those annual fit testing requirements are, still in place and will continue through COVID. And so we have the added challenge in terms of PPE, not just procuring appropriate N95 respirators, but also reaching out to all of both inpatient and outpatient providers to give them that added PPE and protection and, training associated with that, and, of course, the fit testing. So that has been the biggest both challenge and opportunity in those environments to really provide what we need for those individuals. And it's been an ongoing situation. We really had to adapt quickly, provide, trained individuals to be able to perform the fit testing and be able to provide from a supply chain perspective, make sure that the equipment that wouldn't have otherwise been in those environments now have an ample supply to accommodate the need for the influx of these patients, because, the reality is, especially in this part of the world, is that we really have to assume now that every patient is positive when they walk in the door. Certainly our pre-procedure testing and all the things that we're putting in place. But honestly, we don't have a choice, given how prolific the spread is in the community.
Yeah. Jessica, how about from your perspective, anything different?
No, I completely agree with what Joanna said about that. We have to treat everybody now as if they have COVID. And so, completely in agreement with her.
Okay. How about considering the cleanliness of the environment? So, PPE for staff and, masks for patients, but how about high touch points, curtains, linens, restrooms? Are you doing anything different there? Joanna or Jessica?
Yeah, this is Joanna. The biggest challenge has, again, been in those environments where we're not used to having, patients who need to be isolated. So, for example, in the hospital environment, we have increased frequency in terms of rounding and high-touch services, cleaning-wise. But that wasn't really very far off from what our normal procedures were, especially related to the different types of both standard and transmission-based precautions. The challenge really has been in those ambulatory sites where they're not used to having, even conceptually isolating people or, having specific precautions relative to those environments. And, in a lot of cases, we're talking about not a, ambulatory surgery center or a outpatient services building that is really considered part of a hospital. We're talking about freestanding, essentially, office space. And so we have to then adapt, the hospital process to those environments, and in some cases they didn't really exist because we're talking about office space, but office space that patients frequent, obviously. So that created some additional resources, supplies, patient care staff, whether it was MAs, providers, or nurses, had, really have responsibility to kind of be in control of the environment, and especially in those patient care areas, in between patients, so that those responsibilities then get extended to to those folks, as well as additional both staffing resources and product and processes associated with creating, those safe environments in the ambulatory setting. And, to get even down to, shielding and plexiglass for those reception areas where patients would come in and be registered, and who cleans that, and so it has been a massive process to get those things in place, to provide the safest environments for our patient populations. And it's been amazing to me how that ramp up has been so successful in terms of team players, operationally the business and building management companies, really stepping up to provide what is needed in those environments where, frankly, previously it wasn't a need. So that's a whole change of culture and activity that has really been profound, in those environments with this pandemic.
Yeah, great. Thanks. So, you guys have all been great. There are a lot more questions, but unfortunately we don't have the time to ask them all. But you guys, the panelists, have been great. Thanks, Josh, Jessica, Joanna, and Michael. This is certainly some strange times, and there's certainly lots of things for hospitals and health systems to be thinking about as they continue to deal with the significant challenges of COVID-19. This has been super great. Thank you all for participating. I think that kind of wraps up our session today.
Yes, and piping in on behalf of Becker's, I just want to thank you, Stephanie, and our panelists for such an excellent presentation, and to Vigilance for sponsoring today's webinar. I hope everyone enjoys the rest of your day, and we look forward to having you join us for future webinars.